Our first guest is Dr. Muniswamy. You are an interventional pain physician, and you're with, let me see if I get this right, Central Kentucky Interventional Pain Management Center at Georgetown Community Hospital.
That is correct.
Did I get it all right?
You got it all right.
All right, when we talk about pain, that covers a lot of ground. Tell me about that. What's some of the patients that you see?
Yeah, first of all, thank you for having me on the show. I basically treat chronic pain. Chronic pain is any pain that's greater than 3 months old. If the patient experiences pain for more than 3 months, it's called chronic pain. And the wide range of patients I see is anywhere patients having pain from spinal cord injury to having post-surgical injury, surgical recovery pain, and things like that, and cancer pain too.
And when we talk about pain, we've heard a lot about the opioid crisis and the pill problems.
Right.
But there's ways to treat medication without using opioids or pills.
That is correct. That is correct. Opioid does have its place in treatment of pain, but there are several other things that combine to treat chronic pain, including therapy, physical therapy, body and mind therapy, other oral medications, topical medications not involving opioid, and we have interventional techniques. There are several interventional techniques that has drastically reduced the opioid use.
Now, you mentioned interventional. One of those is the spinal cord stimulator.
That is correct.
Describe that to us.
Yeah, spinal cord stimulator is basically where we are using electrical leads to basically numb the signals that get into the spinal cord, or the pain signals that are getting into the spinal cord. It's basically based on a gate control theory. It basically involves two things. One is trial. During the trial, if the trial is successful, then we go for the implant. During the trial, I basically place two electrical leads into the dorsal part of the spinal cord and connect it to a battery, strap it to the skin, and send the patient home for 5 to 7 days. And if the patient experiences at least 50% of pain reduction and has a better function, was able to perform his activities of daily living better, then it's considered a success. When he comes back, I take the leads, throw it away, and then we schedule them for an implant. During an implant, we do the same thing, place the leads, connect it to a battery. This time we take the battery and put it under the skin.
And that's adjustable. Even if the implantable ones, you can adjust the
you can adjust the frequency, the width based on the coverage, where you want the coverage, where you place the leads. If the pain is more in the feet as compared to the back, you can adjust the width and the frequency and the intensity of the stimulation.
And what's the success rate?
Success rate is ranges widely between 40 to 70%. Basically, depends on the patient selection is the most important part. Okay. Not every pain can be treated by spinal cord stimulators. So there are two kinds of pain: nociceptive pain and neuropathic pain. A patient who has more of neuropathic pain experiences a better relief with spinal cord stimulators.
Now, another interventional problem is I think it's called, if I get this right, intrathecal pain pump.
That is correct.
Describe that to me.
The intrathecal pain pump has been there for a long time. It's been there it was more among the chronic cancer patients. What we do for this is we basically place a catheter, a tube into the intrathecal space, connect it to a pump, and place the pump right under the skin. It could be anywhere in the belly or in the back. And we fill the medications every 3 months, every 3 to 5 months, depending on the usage. We fill the medications, and the medication flows constantly into the intrathecal space, providing excellent relief. And it is one of the best ways to control pain, because the pain receptors, it goes straight to the pain receptors, treated very regionally, and less number of side effects.
And that's adjustable too, even though it's under the skin and implanted.
Yes, it is adjustable. We have even a patient therapy manager where we can adjust the dosage. We can increase the dose, decrease the dose based on the patient's comfort level.
Okay. Then one other thing too is I believe it's called nerve ablation. You basically deaden or kill the nerve to try to kill the pain.
Yeah, that is one of it's a very good technique when you have pain that is related to your facet in the back, your lumbar spondylosis or cervical spondylosis, where we block the nerve. If the block is successful, then we go and do a radiofrequency ablation, where we get enough of the nerve so that we can control the pain for a longer period of time. Patients have relief anywhere between 6 months to 2 years.
You also do injections.
Yes. Injections has been the bread and butter of interventional pain, like epidural steroid injections, intra-articular injections for the knee, hip, and any other joint in the body too.
That's great information, and that's all great pain relief without an oral medication.